Case 4 is a ASD case. It's a 61 years old woman who has known history of ASD but defaulted follow-up. She was admitted for syncope, and we performed a transthoracic echo showing a moderate to severe dilated right ventricle. We suspect to have a ASD with left to right shunt on transthoracic echo. Nice. Therefore, we perform the transesophageal echo. We show a circumdum ASD, measure a size of 1.48 to times 1.86, with again deficient retroaortic rims. The pulmonary venous drainage is normal, and there's moderate to severe right ventricular dilatation. There's moderate TR, and the PASP estimate to be 40 millimeter mercury. Next, please. So this is the four-chamber view in the transesophageal echo, which show a moderate to severe dilated right ventricle. So next, please. So we show a ASD with relative deficient retroaortic rims and left to right shunting. So next, please. So we measure the size is around 1.86 times 1. And the other view is 1.47. So next. So there's bicaval view. There's adequate rim in the superior vena cava and also the inferior vena cava. So next, please. So we did the 3D echo and found the dimension to be 1.48 times 1.87. So next, please. So we hand over to the live team.
Would our panelists like to make any comments?
Yeah, any comments to the case? I can say that I measure myself on the TOE pictures just before we went into the room here with Anna. And I think it was, I got two measurements, 16 in one view and 24 in another view. So an average about 20.
So the first thing I would like to ask the indication of kosher of this ASD in a 60-something years old lady.
Yeah, did she have any symptoms? She was short of breath? Yeah. And also I can say that what we have seen here down in the cath lab is that she got some intermittent SVT. I cannot rule out that it's us causing it by the guide wire and catheters. On echo also she had a quite volume overloaded RV. We measure in the beginning of the procedure here, we did a pressure in the pulmonary artery. Mean pressure was 18, so there's no sign of pulmonary hypertension. So I think myself that's a good indication. She's symptomatic. She may have SVT, and she got a volume overloaded RV, moderate side ASD, and no sign of pulmonary hypertension. Does anyone want to leave this ASD?
Any other comment from the panelists?
Yes, if this lady has symptoms, then probably it's good to proceed to it because in the old day, ASD older than 40 years old, we always need to think what is the indication of causing the atrial septal defect. But I agree, if the patient have shortness of breath with exertional deep steer, and there's definite evidence of right ventricular overload, then we should proceed to cause it.
We can see the...
Can we proceed?
Last, can I ask why there's a discrepancy in your measurements whereas with the baseline echo done early on? Is it because of the airway pressure was a little bit higher now, and then that distend the atrium, and then the atrial septum also getting a bit separate apart?
My measurements was actually done on the TOE, the workup she had. So we look forward, we look through all the views, and we find some views where you can actually see it was up to 24 in some views, 16 and 24. So in average, 20.
So last, the posterior inferior rims look quite flimsy, and the retroaortic rims is a bit deficient.
Exactly.
So we'll proceed to do a balloon sizing of the hole with stop flow technique.
Would everyone do that?
Yes, I suggest to do it. So any other comment from the panel?
Yeah, this is Dr. Arita in Japan. To me, the posterior rim really floppy. I think at least 20 or could be 22 or something would be appropriate. Okay.
But let's see the angiogram. Can we swap to fluoro? With the balloon?
We don't see angio here.
Next.
Balloon.
So here's a balloon. It's a 35 millimeter balloon coming with the Oclotech system, and it's inflated to a stop flow position. There's 5 millimeter between each marker, so 10 millimeters from marker 1 to the third marker. And from this measurement, we got a measurement of between 24 and 25, which was very close to what we got on measuring on the balloon with eyes.
Do you have an echo picture, the stop flow?
With the balloon?
Yeah, with the balloon.
I think no. Unfortunately, we didn't store that.
And what is the total septal length?
We haven't measured, but I think it's it seems to be at least 4 centimeter. We can see echo again if we swap to eyes. So I think there should be room enough for a large, but not extremely large, but a large device. So again, it's about 20 millimeter unstretched. It's 24, 25 with a balloon to a stop flow position. A little bit flimsy rim. So any suggestions for which device we can say we're going to close it using an Oclotech? They come in 21, 24, 27, 30.
So the unstretched diameter is around 20, and the stretched and the balloon size diameter are 24 to 25. And,
yes.
And the vitreotic rim is inadequate. So probably so if you go up for 2 millimeter, it's around 27. But but that the posterior rim is a little bit floppy. I think a 27, 28 device will cause the defect.
If you're going to use an Oclotech, it's come with steps in 3 millimeter in this range. So it's 24, 27, 30.
I think a 27 first.
有冇30?
27. You want to swap?
That's much
That's
much easier because you have a less choice.
Yeah. So I would suggest that Anna and I load the device. You go to the room next door. I think they're quite keen to continue with the LAA case.
Are you ready to deploy the device?
We have loaded a 27
why
millimeter.
Don't you do that first before our lecture?
27 millimeter Oclotech in a 12 French sheet. We can see eyes. Echo, please. Can we see echo? So you see the short axis aortic valve. You see the sheet is across this septum, and if you see echo and fluoroscopy, picture in picture.
兩個.
Can we see fluoroscopy as well? Picture in picture.
Lars, before you deploy the device, is the patient in AFib?
The patient has been in AFib during the whole procedure.
So, but before the procedure, was the patient in sinus rhythm or AFib?
Yes.
Was it
in sinus?
He was in sinus rhythm, yeah.
So why do you want to deploy the device before you revert the patient to sinus rhythm? Just in case you need to cardiovert them.
She's in a local anesthesia. She's awake, so then we have to sedate her.
I would advise you to do that because I was burnt with this before by cardioverting the patient after the device, and the device embolized.
But then we need to call anesthesia down and put it.
I would call them. you know, I would do that for the patient before you deploy the device, because if she's in AFib, it's better to revert her to sinus, even if you have to put her under anesthesia, then you put your device safely. That's my advice.
But I think I've seen this several times, and often provoked by the instrumentation, and sometimes it just disappears when you take the sheets out of you give one dose of amiodarone, and I often just wait 24 hours to see what happened. But I mean, it's a very good point to do it. What do you think, Anna? Should we proceed here?
Yeah. Because apparently it's in and out. Sometimes it's sinus, sometimes it's...
So Anna is saying it's also here in the cath lab, she's coming not in it all the time. So I'll look at echo and fluoroscopy. Bring the left disc out like this, and we are pretty fine. We can come a little bit back. We don't really see the device yet. Here we are. So again, as the previous case, we have to try to stay in the left side, not coming so, see if we can get a little bit better eyes. Yeah, so I think we captured. So we can just see echo large, please. So you can see the posterior rim is in between the two discs, and the two discs are splaying around the aortic root. The device doesn't seem oversized. It's not mushroom shaped. It's a flat device. We can see if we can get a little bit more long axis view. Like this. What do you think?
I think it looks in a great position. Yeah. And this is, in my opinion, the advantage of the flex catheter is the excellent alignment of the device with the septum. This looks a beautiful result aside from the AFib, of course.
So let's see the camera and fluoroscopy picks and pick. And see fluoroscopy as well. Can we see camera and fluoroscopy? I'm going to unscrew this safety bottom, so I'm ready to release. I want you to see the... Okay. So I'll open it up for the device, and it's released. Good. And we can go 40 degrees LAO. See the device in a nice position. And we can just end up looking at echo. After releasing the... So I think it looks in a nice position. It's a flat. We can put some color on, Anna, just to make sure there's no shot across.
Nothing.
No. So we're happy here. What about the audience and the panel?
Any comment?
So, Dr. Lars, will you routinely assess the mitral annulus and the relationship between the mitral annulus and the edge of the device before you release the device?
Not before we release it, because it's very difficult to judge it, because you have tension from the cable and it'll change position when you release it. But I do it before implantation. I check the rim to the aortic root, the posterior rim, SVC, IVC, and the mitral valve. And we need, of course, to have at least 5 millimeter rim, except for the aortic root, where we can do it with a deficient rim.
Do you find that the intracatheter echo sometimes have difficulty to assess the mitral valve?
I think ICE is difficult if you don't have the experience in it. We have a person, actually 2 persons in our center who's very, very skilled, and they come down, do the ICE during the procedure, and you get fantastic images, much better than I can do here as an interventionist.
So any comment?
Any other comment?
Yeah, I believe ICE is an excellent technology. You can assist everything as much as you can do TE. So as Lars mentioned, it depends on the operator. If you are not skilled, then you will find difficulty in assessing. But if you use it day in and day out, it's just like TE.
Yeah.
Agree.
Thank you very much. Thank you, Prince of Wales Hospital.